Good morning, good afternoon, and good evening. My name is Asli Heitzer. I'm the project manager of the Capacity Building in Africa project at the Global HIV Vaccine Enterprise of the International AIDS Society. And it is my big pleasure to open this webinar on adolescent girls and young women in HIV research and prevention, which is organized from the Global HIV Vaccine Enterprise together with IAVI. It is the second in the last one in a 2 webinar series. And I would like to heartily and warmly welcome all our participants, as well as our speakers and panelists who will be introduced shortly. Today, we will try to understand AGYW needs from a human-centered lens, and also understand ways through which we can better engage AGYW in HIV research programs. This session brings together experts from the field of human-centered design, behavioral science, social norms, and social psychology to share insights on what we have learned in the past about AGYW behaviors through various RNA programs and deliberate on how we can leverage these learnings to enhance better engagement in HIV programs. I would like to let you know that all participants are muted at this stage, but we highly encourage you to post all your questions through the Q&A box, which is located at the bottom of your screen. It's my pleasure to introduce our chair today, Devi Bose. And Devi is a senior manager of programs at IAVI in New Delhi, India. And she leads the design, advocacy, and on-ground implementation of strategies that promote communicative justice, enable community trust and ownership in public health programs and prevention research. She leveraged her interdisciplinary training in human-centered design, participatory research, and public policy to design research to understand the complexities of human behavior across varying contexts and develop social and behavioral change, communication strategies that support mainstreaming and equitable engagement of marginalized communities in healthcare. Leena, it's my pleasure, and I will hand over to you to lead this panel discussion and webinar.
Thank you so much, Asli, for that introduction. Welcome everyone to this exciting webinar where we today unpack lessons from behavioral research to better understand how we can improve strategies for engaging AGYW communities in HIV programs and research, and how it can inform various aspects of the product development, introduction, and rollout. For those who might not be very familiar with what behavioral research is, it is basically an umbrella term used to describe research in the social and behavioral sciences, social work, and management, and deals with human behavior in real-world settings. We have a very illustrious panel today, and very thankful to all our panelists who have agreed to share their learnings from the phenomenal work that they've been doing in the field of behavioral studies. So without much delay, let me introduce our first panelist, Uttara Bharath Kumar. Uttara has over 29 years of experience in public health, social and behavior change communication. She, as a senior social and behavior change and capacity strengthening advisor, she has been with Johns Hopkins University Center for Communication Programs since 1997. And among other global programs, she and her team also support the Bernard Van Leer Foundation in India, bringing behavioral lens to their work. She has led numerous training programs on global health communication initiatives, including some that have won recognition and awards. She has a master's degree in public health from Johns Hopkins Bloomberg School of Public Health. Uttara today would be talking about how social networks and social norms influence participation and decision-making among AGYW. Over to you, Uttara.
Thank you so much, Devi Leena, for that very kind introduction. 7 minutes is a very short time when you think about it. So I'm going to try and just expose everyone to a few concepts, a few ideas around this idea of social norms. I'm going to share my screen, if I may. Okay, so let me just jump right into it.
No, I think we lost the connection.
Let's just see for a minute and see if Uttara can join us back. Okay, no matter how well we prepare, technical glitches do happen. So maybe Francis, I might probably invite you, and we can have Uttara once she joins back. Francis Meyo is current Vice President Projects at Busara. His interests range from how to best behaviorally design and introduce innovative products in health, finance, and digital spaces, to evaluating which opportunities exist for behavior change in population with various abilities and capabilities. He has worked in multiple projects for the development of knowledge products, go-to-market strategies such as and strategic support services to organizations setting up or training their behavioral science teams. He's currently supporting the development of demand creation strategies in several sub-Saharan countries for the DPV ring, which is the Depavarine ring. And prior to Busara, he has also worked in various research and policy capabilities and innovation for poverty action. Francis today will give an overview on how behavioral barriers can hinder the adoption of new or available SRH prevention products. Over to you, Francis.
Thank you very much, Devi, and good afternoon, good evening, good morning to everyone who's joined. It's a pleasure to be with you today. I don't have a deck, but I'd like to cover three things in the few minutes that I have to present. The three things are, when we are talking about behavioral barriers, who specifically are we referring to? Is it the end users, the various products or services we intend to reach? Is it healthcare providers? Is it product developers? Is it advocacy partners? Is it folks, other support networks in outreach centers, and just a whole host of other stakeholders? That's a question I will pause and perhaps not answer right now, but it's important for us to think about it. The second and the third thing that I'd like to talk about is focus on these behavioral barriers, one, with an already available product in the market, that is oral PrEP, and share some of the reflections we have based on some work we've done. And two, share some reflections on a soon to be available product in the market, the Piven ring that Devi mentioned. To start with oral PrEP, I invite you to reflect on what would a typical user journey be on that. And for this, I'd try and limit it to the three most active stages for oral PrEP utilization, let me say. The daily intake of oral PrEP, that is, what's the experience of folks taking oral PrEP daily? The continued use of oral PrEP, what barriers, what levers are there in maintaining the continued use of oral PrEP? And three, sort of the societal views. What role do we think society, relationships, social networks play in the decision and utilization for oral PrEP? If you think of that user journey in those three ways, some of the barriers that I think one would encounter is when you start off with a daily intake of oral PrEP, just difficult in the consistency. It is rather hard to be taking the pill on the regular, daily, for that matter. The second one that we found, particularly with some key populations, MSMs, for example, FSWs, is would there be drug use involved as well? What other behaviors are at play when someone is engaging in their day-to-day life, but do have to take this HIV prevention product that we've provided. And then just cutting across, I think, all the three stages, what does the social support system looks like? Is it there? Is it not there? Right? If there is something to be considered around the continued use of oral PrEP, what we found similar is there concern around side effects? Is there discomfort in talking about safe sex if you have multiple partners, right? And therefore are trying to advocate for yourself in terms of what you are using. When it comes to societal views, we found that there is quite a lot of stigma as well that may be associated with, are you taking oral PrEP because perhaps you are promiscuous, but perhaps because you have multiple partners, and there may be stigma associated with that. Moving to the third thing that I'd like to talk about is in relation to this new soon to be available product in the market, that the Piven ring. When you look at an individual user's journey, what are the various segments that may exist in that community that we are serving. At Busara, what we've tried doing quite a bit, and the gospel that we preach is a persona-based segmentation based on characteristics for end users, HOAWs, that will have them distinct from one another in that community that we are serving. And try to better understand what information sources are people accessing. How does that shape their knowledge, their beliefs, their attitudes? What are the relationships like? Is it supportive? Is it not? What are the objective and subjective risks of HIV? How do they perceive the ring as a prevention product as well? For that, we've found roughly 3 broad. This is work we've done in about 8 countries at the moment. We found a ring advocate, a concerned woman, and a trusting woman. And you can imagine that the barriers that they face, the levers, the behavioral levers that they may have at their disposal are quite broad and have an interplay with each other in terms of the propensity for ring adoption. For the ring advocate, just very quickly, side effects is quite a high barrier that they are worried about, as well as any costs that may be associated with the ring use. They also have quite a bit of, they have quite a high amount of subjective risk for themselves, and their ability to know that they want to protect themselves, say, from HIV, does make them really good advocates for the ring. For the concerned woman, there are concerns around would the ring dislodge, say, when being used. It's a ring that you insert and use for 30 days or so. And levers are, would there be a difference in pleasure when engaging in sexual activity as well? And then for the trusting woman, it's, do I insert the ring and use it, or do I not? What's the efficacy of the ring? And perhaps are there other backup options that may be available for them? So that's sort of what I'd hoped to share today. And I look forward to any questions that may arise from it. Thank you.
Thank you so much, Francis, for that insight on how you've carried on the user segmentation. I'm going to go to Uttara now, and Uttara would be talking about how social networks and social norms influence participation and decision making among AGY.
My apologies for jumping off in here. I'll start from this slide since I've a little bit less time. What I wanted to talk about was how a number of things influence how decisions making happens with young people and their behaviors, and how important it is to measure them. So if you look at this ideational theory, we have a number of things like the knowledge, the attitudes, personal advocacy, social support, emotion, self-efficacy, perceived risk. We could go on and on. So it's much more than what people normally think, which is just knowledge and tell people something and they'll do it, right? So especially with young people, it's critical that we really understand where they're coming from. And many of these are really affected by the social norms, their perceived social norms, what they think people think of them, what they think of their behavior, and so on. So I'll just give you a quick example. That was a study that was done in Zambia many years ago. And while it's been a while, it still holds good. But let me give you a little background to that. So if you think about communication, we want to think about the instruction. Is it directive, non-directive, public? And are we influencing skills and knowledge? Are we influencing ideational factors like the ones that I just talked about, things like cognitive, emotional, and factors that are, beliefs, values, perceived risk, etc. Or are we talking about environmental issues, which are supports and constraints to their behavior? And this in turn leads to their intention to practice, and then finally the behavior, right? So an enabling environment with social norms that are supportive are critical. And for that, we need to understand their social norms, and research is absolutely critical to that. So in a study that was done in Zambia, looking at ideational factors related to condom use, and it was among young people, male and female, 13 to 19 years old, and looking at things like their perception of risk for contracting HIV, knowing at least 3 ways to protect themselves. How have they talked to at least 3 people about safe sex? Do they have a positive attitude towards people who use condoms? Know where to perceive condoms? So each of these things was seen as an additional factor that supported or helped them. And the social norms that define how people see HIV, what are some of the stigmatizing issues around it, etc., greatly determined also some of these factors. So when we saw what happened was very interesting. Those young people with one factor had a certain likelihood of condom use. Whereas if they have 2 factors, positive factors, it increased greatly their likelihood of using condoms. 3 factors, even more, and so on, which shows the cumulative effect of these ideational factors. And unless we understand what they are, it's difficult to really know how to influence them, right? So in the modern times, now we're talking about things like human-centered design, right? So we look at it, we may not have the resources or the time to ideally do great in-depth research, behavioral research, which ideally we'd like to do, but not all projects have that luxury. So instead, human-centered design looks at desk reviews, stakeholder mapping, partner selection, formative research, insight generation, etc., and looks at ways looks at a social and behavioral diagnosis. So also in Zambia, a few years later, what was developed was a number of different interventions that came out of these behavioral insights that helped understand young people's behaviors. And a couple of the key things that came out was, one, that they felt the lack of confidentiality to seek services at the clinics or health centers with health providers. So the lack of confidentiality was a big issue. And the second was that there was never any attention or time dedicated for them. The youth-centered corners didn't quite work because there's always other priorities. People would see them come and go. So how do we address that? So a number of prototypes were developed and tested around these 2 key behavioral insights. And what came out of it was actually very interesting. An adolescent wellness day that was dedicated just to young people. So once a month, there would be a day where the young people could come and receive services, and it was just dedicated to them. And these included things like family planning, HIV testing, discussion around malaria, but also included things like young people's wellness, how to stay fit, how to, tips about being well, etc. So a peer advisor along with the community and school would be involved, and the adolescents would participate in group activities as well during that day. And the providers would use a toolkit to systematically discuss various issues, but these providers were also trained to be better about maintaining confidentiality with the young people. So ultimately what happened was, 130 wellness days were held, and a lot of adolescents attended and had very, very positive feedback. And you can see the lines were so long because they were very happy to see it was something that was specifically addressing their needs. So where they wouldn't come to the clinics, now you suddenly had a whole different view, because what was developed as an intervention was very specifically with their research in mind. So I'll stop right there. That's a lot of information in a very short amount of time, but I'm happy to discuss and answer any questions later. Thank you.
Thank you so much, Uttara, for sharing those insights. I'm sure there are more questions which are going to come in the question box. Please keep sharing your questions, and we'll be taking them towards the end of the presentation. Now I'm going to go over to Anabel. Anabel Gomez is a public health professional with more than 20 years of experience. Most of her work is focused on HIV prevention. She has worked on IAVI's Prevention Market Manager program, where she led all the end user work supported by JPIGO's Chilinde project, which was charged with introducing PrEP to Kenya, and worked as part of PSI's global marketing team in charge of sub-Saharan Africa. Anabel will today share her understanding on integrating insights from behavioral research in HIV prevention product design. Over to you, Anabel.
Hi, and thank you, everybody. Like the other presenters, I'm going to move through this fairly quickly, but I would be more than happy to answer any questions afterwards. I'm just trying to see if I can shift this. Okay. Sorry, I'm having problems moving to next slide. Ashley, can you take back the control? I'm sorry, it doesn't seem to want to move the next slide for whatever reason. Thank you. Can we go to the next slide and the next one? So what I'm going to do is talk you through the current context. I'm going to give you 3 examples of points where and projects where end user insights have been gathered early in the development phase, and then do a couple of slides on what we can do next and what needs to be done. So I think we can all agree that biomedical approaches are obviously very needed, and we're in a very exciting time with HIV prevention at the moment, with a lot of new biomedical approaches and technologies coming on board. And we heard Francis talking about sort of the ring a few minutes ago. We've also got Cabernet. So it's a time of great excitement and great promise for HIV prevention right now. But what we have been seeing is a lot of the times, a lot of the products, it's a very top-down situation where global health may decide that there's a need, or see that there is a need for a product, and it is global health that drives the demand for the product. It is more a product looking for a market rather than the sort of the demand for the product coming from the market itself. And what then happens is a lot of times the products, certainly in the early development phase, we don't take into account the user, and the user may be any one of those 3 categories that Francis spoke about earlier. And because of this, there is inherent risk in the product as we move forward. Next slide, please. So not involving the consumer from the start, it comes with quite a lot of risk. It comes with sort of all the problems that we just heard before in terms of getting from Uttara and Francis, in terms of getting people emotionally connected, comfortable with the product, wanting to use the product, not talking to people about their states, the emotional states, and how they could relate to the product, not understanding what would make somebody not just use a product, but desire the product. And we know that just because something is good for you, people aren't going to use it. So we really need to move beyond focusing on sort of the objective utility of the program, of a product, in when we're doing in the development stage, and asking sort of better questions of the consumer, the user, the provider, whichever user group you're talking about, and really trying to introduce human factors early in that product development, along with science, and have those both those lenses moving together in order to really try and mitigate risk on the product, so that we are not having to overcome issues later down when we are actually trying to scale the product. Can we go to the next slide, please? Typically, those green chevrons is where we get some interaction from users with the product, and by that stage, certainly by clinical trial stage, there is not a lot of degrees of freedom for us to change very much around the product. Obviously the formulation is set. We may have some space around packaging, but we probably don't have a lot of space around delivery mechanisms or a lot of the product attributes. And what I'm advocating for is to actually get those end user results, not just at that implementation and stage, and really try and get them earlier in that research discovery phase. And while I understand that clinical trials do get some user insights in terms of acceptability, their key purpose is really to answer scientific questions more than anything else. So again, trying to get that user research early in that discovery phase, so that we can go into clinical trials, answering maybe more than scientific questions, answering questions around behaviours and how that may impact the science is really important, and getting sort of those learnings all the way down that chevron as much as we can would be not only useful, but also, as I said, would de-risk the product and help us A, fail fast, and B, be more effective in our global impacts. Next slide, please. So I'm going to talk about 3 examples of where we did find some early learnings from users in product development. Can we go to the next slide? This is a DCE that was conducted by over 1,000 women in 2 very distinct areas in South Africa, and we looked at 4 formats, so 4 interventions. The pill, the implant, the injection, and the vaginal ring. We looked at dosing, we looked at side effects, we looked at site of administration, who was doing the administration, but we also looked at things like discretion, ease of use. So a lot of the I guess issues that make people connect and feel more comfortable with using or even testing the product. Next slide, please. And what we found was some very clear guidance in terms of what users wanted and which product they preferred and why. And the top of the list was actually the 3-month injection. The second one was actually a monthly pill. Next slide, please. But sort of what we learned in terms of getting user behaviours in there was, even at that early stage of research, there are opportunities to learn more. There are opportunities to provide some guidance in terms of investments, and there are opportunities to actually think about the product and see how you can actually align it with the user needs, even if it's something like a preference for the injection or an implant, which the women spoke about greatly. Next slide, please. This is the second case study. This was for a dual prevention pill, and we conducted 180 interviews in Zimbabwe and South Africa. We focused a lot on packaging, and also, next slide, please, the colour of the pill. A lot of this was because we learned from PrEP that packaging, the rattling bottle was a major barrier to use. And also people didn't want a white pill because it reminded them of ARVs, and it was an issue they didn't want people thinking they were taking antiretrovirals because they had HIV. So a fair bit of effort was put in to learn. What was terrific about this project, next slide please, is that we got to work with the developers and actually, spoke to the people that were doing the manufacturing of the DPP and actually try to understand what were the degrees of freedoms, what we could do with packaging that might actually help a woman know when she was, for example, just taking the ARV and not taking the contraceptive, because obviously you've got to take an ARV for 30 days and a contraceptive for 21. So they could understand not to share pills. But the great sort of learning from this was, even if parts of the product are locked down, like the formulation, there was still a lot of room to get that user insight and to really come up with a product that was going to be more acceptable to the end user, and there was a lot, and help them connect with the product and actually want to use it. The third example, next slide please, comes from the family planning. And this was for an external family planning product. And I can't give you the name because of commercial confidentiality, but the idea was to get insights, not just from the women that were likely to use it, but also from providers, and see how they felt about the product and what they felt and how they felt they may use a product. And because this was a patch, there needed to be a bit more education than, say, for example, an injection or an oral tablet. So they wanted to get it right, and they put a lot of effort into getting it right. Next slide, please. So what happened is we did there was journey mapping conducted by Ipsos, who conducted the research, and 4 prototypes came out of that. They worked with the developers to come up with 4 prototypes. The 4 prototypes were then tested amongst women and the providers, aspects of each of those prototypes were then fed back to development for figuring out how to go forward. And this also helped the donor understand what the value of this product was for the women involved. Next slide, please. So again, getting that user feedback and understanding what trade-offs people are willing to make between product features, which is where the prototypes came in, and illustrated it very vividly, really helped getting that user insight and coming up with, again, a product that somebody's more likely to use, but also really helped the developers understand the ecosystems that they were entering into with this product, and really brought it home to them, because for a lot of times these developers are in the global north and we're servicing populations in the global south, and that, you know, there is sometimes not such a great understanding of clinical restrictions or the restrictions, the ecosystems that the user will work in. Next slide, please. So I'm just going to finish up now with giving some ideas of what we can do to get these user insights early. Next slide, please. This is a theory of change in a bit of a different sort of format than what we're used to seeing. I'm just going to focus on the inputs and the two sort of outcomes on the outside, but do look at Design for Health. This is where this has come from, and it's a brilliant site. And the inputs, when we're talking about open-mindedness to change, open-mindedness to be adaptable and flexible, and that's a lot easier to be in that research and development phase where there is wiggle room versus when you've already got a finished product. Have a multidisciplinary team, actually, you know, have different voices in the room. When I talk about problem-centeredness, I'm actually talking about user-centeredness, understanding the problem, not just that you're trying to fix medically, but actually the problems that the users are actually facing currently and may face with the uptake of the product. Want to change the way things are, want to change your product, and actually have some support for it. And I think ultimately what we're after is, you know, better results in terms of global health impact, but also we want to increase equity and inclusion and give everybody a voice that is going to actually take this product and increase the sort of the quality and the quantity and the adoption of innovation, so that we're not facing problems at implementation phase that could have possibly been fixed at research phase. And this is my final slide, so next slide. And I do apologise for moving quickly. So here's some of the things that you can do or that developers can do, and that we should be advocating for them to do, which is to build time and resources into product development timelines that allow for the user voice to be heard early. You know, not rush through, just really when you're doing your timelines, make sure that there is space for that user voice to be heard. Also make sure that when you do have that user in the room, that it is the right user, that it is the right target audience. You know, adolescent girls and young women is a very broad audience, and we can narrow it demographically, but even, you know, I've seen projects that their user group ends up being a very empowered young woman, and that is not who we're really trying to target the product for. There is a range of women, some empowered, some unempowered, you know, a range of agency, but make sure that who you have in that room is representative versus people that might be easy to get into the room. Actively ask questions that will help you decide on the product attributes as early as possible. You know, does it increase discretion? Who can deliver the product? Can it be a nurse? Can it be a nurse in a mobile clinic? Things that are going to affect uptake. And I think lastly, always question yourself, have you done enough to give your user a voice? How do you make sure that they have an equitable voice in this design? Because I think that's absolutely crucial. And if you're a donor, ask yourself how you're incentivizing the developer. Is it speed to bring the product to market, or is it actually incorporating that user voice? And how are you measuring success of a product to go to the next stage? So these are some practical things that you can do. But I think unless we start getting user input earlier on in the design phase, we're going to keep facing similar problems in that implementation phase. So what can we do to reduce and to maybe de-risk? Doesn't mean it's going to be smooth sailing, but at least maybe we'll be able to reduce some of the barriers that we heard about earlier. Thank you.
Thank you so much, Anabel, for that. I'm now going to move on to Yvonne, who's the Director for Social and Behavior Research at IAVI. She is based in Nairobi, and she leads strategic development and guides the global execution of all aspects of IAVI's SBR portfolio. Yvonne has 18 years of experience working across multiple countries: Kenya, Botswana, Ethiopia, Ghana, Tanzania, Uganda, and Zambia, and conducting SBR on a variety of social and public health subjects, including malaria, nutrition, maternal and child health, and health systems. Yvonne today will be sharing notes on integrating insights from behavioral studies for designing AGYW-centered strategies for engagement in HIV research. Over to you, Yvonne.
Thank you so much, Leena, and it's my pleasure to be one of the panelists in today's webinar. Basically, I'll talk through designing AGYW-centered strategies around their engagement in research, and also briefly speaking to the ethics of research that's AGYW-centered, as well as participatory data collection methods that take into consideration the demographics of adolescent girls and young women. And then I'll conclude with some insights from behavioral studies, what has worked, what has not, and what the gaps are. Really here when we are talking about AGYW-centered strategies, we're really thinking about human-centered design, which the previous panelists have talked quite a bit about. So it's basically a creative approach to problem solving. So you start with the people you're designing the product for. In this instance, would be starting with the AGYW, and ends with solutions or products that are actually built to suit their needs. So just to add that this is an emerging area of exploration and learning. There's not as much literature around it. And also this is tied to the fact that the process of generating insights and also deriving solutions, deriving products is not a really linear or streamlined process. So I'd like to start by talking about, in terms of how exactly we go about designing research that is more user-centered. So there are various things that we need to take into consideration. Number one is the fact that if we are deciding that AGYW are at the center of HIV prevention research, then we need to have research that is a continuous learning approach in terms of its design and implementation, and that it's also research that integrates both the generation and use of insights from the AGYW throughout each stage of the process. So we're essentially saying that, AGYW-centered strategies not only apply into, the processes for doing the research, but also the study conceptualization, study design, and study monitoring, as well as design and testing of various HIV prevention products, as well as interventions. So let's look at it in terms of 3 stages. I'd like you to go on a journey with me. You need to plan a journey, from Nairobi, which is where I am, to Mombasa, which is right at the coast of Kenya. So you need to figure out, how you're getting there, the logistics for, going about your trip. So initially you need to think about how the trip will exactly work out. What means of transport will you use? How will you get there? And how do you make the trip as comfortable as possible? So let's start at the planning level of your journey. So this is what I'll call the early stage of research. So in the early stage of research, our considerations really should be in integrating insights from adolescent girls and young women that focus on what the user's journey is, what their mindset is, what their decision-making ability is, and taking age into consideration, given, we have a very broad age band for the adolescents. Also looking at decision-making ability in the context that, you have adolescents who are minors, what are the social cultural norms which have been spoken about, and also what are the motivations to use or not use products, and motivations can either be intrinsic or extrinsic. So in the early stage, we need to think about, and this early stage means where you're thinking about what studies to do, and when you're conceptualizing and designing the ideas. So we need to collect insights from adolescents that actually talk about how they understand problems and challenges based on their experiences, and actually frame our study objectives around that. And an example I'll give is a study called Illicit, which we are running with IAVI and our partners, where we've actually engaged adolescent girls and young women and other populations of interest that we are working with in the development of gamified tools and interventions that are intended for enhancing research literacy as well as encouraging participation. We are also running another study called MAGI in 4 countries, Kenya, Uganda, Rwanda, and South Africa, where we are actually gathering the perspective of adolescents to understand what do they think clinical trial designs should look like, what would encourage them to actually participate. So this is when we are talking about the ideation and inspiration stage. Then it comes to actually where you're, designing your product or prototyping your product or testing your product, and it can be a product, it can be an intervention, it can be a service. So here we really need to think about having insights from adolescent girls and young women to actually refine solutions, to actually get their feedback. And this is an iterative process, where you keep coming back to them. And I'll give you an example of a study we are running in Kenya and Uganda. It's called the Uptake Study. And it's phased in 4 stages, where we're basically trying to understand preferences for HIV prevention products and what actually informs those preferences. And the first stage of the study is actually was an exploratory phase where we did collect views from a sample of adolescents in both countries. And that is what will actually be used or is being used to inform subsequent stages of the study. So this is an example of how you can actually engage adolescents in the design process as well. So we've talked about early stage, where you're about to leave for your journey. And then we have the stage where you actually want to know whether your product, your service works. So is your journey actually going to happen? Is your car in good condition? The last stage is around actually implementing and conducting specific research. And here we need to think about how we collect insights from adolescent girls and young women in terms of their feedback, their learnings from the research. And we are conducting a number of studies where we are exploring acceptability of non-conventional sampling techniques that are being used in clinical trials. And this is getting perspectives from the participants as they are part of the trial itself, and actually improving the design of the study as you move along. So there are 4 things we basically need to think about in terms of those 3 stages. So you're preparing for your journey, you're about to go on the journey, and then you get off. We need to think about empathy. So empathy means that we are actually gaining insights from adolescents from their perspective. And so we are designing products and solutions that actually speak to the user's needs, speak to what they want, and that at the end helps us create meaningful solutions. Then the second mindset we need to have in designing these strategies is iteration, which is basically repetition. So this is really core to the design process, and it's informed by the mindset of really learning and failing first as well. Failing is a lesson. So beyond the formative stages of the design process, it means we are continuously generating insights by seeking feedback from adolescents. And even if we're talking about products, through rapid prototyping and iterating and refining the products or all the interventions as we go along. The third thing is immersing ourselves in the research community that we are working in. So that means that you're actually using immersive techniques to help us design studies that are based on the user's context. And then lastly is the act of making. So the act of making is basically a mindset where we are creating a solution that can be communicated to others, or a product that can be communicated to others. So we've talked about the 3 stages where we can involve adolescents in the research process. And we've also talked about the mindsets that actually need to be employed in in doing this research. So the other aspect that now needs to come in is, what is the literature saying in terms of what works and what doesn't work? So depending on whether you're designing an AGYW intervention or an AGYW program that's informed by research, there's the need to consider various aspects at an individual level, from a behavioral perspective, also considering structural aspects and biomedical aspects. So examples of behavioral aspects is, risk perception. How, what is the risk perception of the adolescents that you're working with in terms of whether they would need and use a HIV prevention product? And then structural relate to, the healthcare system, as well as, the regulatory system around various aspects related to AGYW, whether it's economic, whether it's educational, and so on and so forth. So in terms of the gaps, and I'm just about to conclude now, we have some gaps around documenting of insights throughout the research process. So that's one of the gaps that is there. So a lot of the literature talks about, there's greater attention to documenting in detail the design process and the learning that emerges from that. But we actually need to understand, human-centered design where we're speaking to AGYW at all stages. We also have gaps around defining and using, AGYW-centered mindsets and principles. So there is the sense that researchers working with AGYW don't have a consistent understanding of, AGYW-centered mindsets or principles and how you apply them in the process. And then lastly is really around building knowledge, alignment around AGYW-centered studies, and this webinar is a good example of that. There's really limited published material on the effectiveness of AGYW-centered design, or the value of getting the insights from adolescents in the generation of HIV prevention products. So I'll stop there, and thank you very much for your attention.
Thank you so much, Yvonne. May I request all the panelists to probably turn their cameras on now? Maybe we could take some questions out now. And as you put your cameras on, I think this is a question which is for all the panelists here. Behavioral research is a well-established field, and we have seen different disciplines leveraging on its insight to promote gradual and sustainable change in various domains. Do you think that HIV research and biomedical science have adequately understood and leveraged the power of this field? What are the opportunities for interdisciplinary collaboration that you feel exist to ensure better demand, to better create demand, uptake, and outreach for new HIV prevention products? Maybe, Francis, we can start with you, probably.
Yeah, sure. Thank you. So my contribution to this would be, what tools or methods does behavioral science research provide that other, if it's and to support biomedical research, but if it's in gender studies, if it's in sexual research, if it's in very sector specific research, you would. And one thing that I constantly find is, for behavioral science, we are looking at how do we better get folks we're trying to understand to reveal their preferences, right? As opposed to just stating their preferences. So I think behavioral research does provide some tools and methods for not just doing surveys, whether qual or quant, but getting to measure in a more tighter manner people's preferences for themselves and their peers as well. So I think that's one thing we can better leverage.
Thanks, Francis. Anabel, do you want to come in quickly on that?
I think Francis did a lovely job. I think we can leverage behavioural science practically in the field, but also I think we need to look at donors and developers and figure out how we can leverage behavioural science to get them to understand the users as well. So there's a lot of focus in that sort of, I think, you know, my discussion, a lot of focus on implementation and getting that right. And I think that's absolutely right. But I think we also need to talk to people about the value of behavioural science, of behavioural economics, and moreover, the value of getting meaningful conversations with the user, which is what human-centered design allows us to do, by getting it earlier. That would be my view.
Uttara, over to you. I'm going to ask you whether, you know, we've been hearing a lot about youth-friendly services. Based on your work, what do you think actually makes service more youth-friendly? And if to that, I can also add Bernard's question, which is basically he's asking that, you know, don't you think focusing on girl child and leaving out the boy child is addressing issues regarding HIV increase amongst adolescent girls is also an issue of great concern? Over to you. I think Uttara has lost a connection again. But maybe Yvonne, we can come to you with Bernard's question on what are your thoughts on, you know, a lot of focus being on engaging adolescent girls and young women, while we do know that their partners are equally important, men are equally important. If you could share your thoughts on that.
Yeah, thank you, Devi, Leena. And I think that that's a brilliant question from Bernard. Even though we are talking about AGYW research, any research that engages AGYW needs to consider AGYW, not only them as an individual, but the kind of environment and the relationships that they have beyond themselves. So the kind of relationships they have at a family level, the kind of relationships they have at an intimate level. So AGYWs may be the center of a specific study, but we also do need to integrate research with adolescent boys and young men, as well as other men who may be partners to the AGYW categories of men, age categories rather, and also considering the really important roles that parents and guardians play in decision-making for these adolescent girls and young women. So I do understand the focus is a lot on the adolescent women and not the adolescent men. But really this has been because of the vulnerabilities that have been shown that are very specific to adolescent girls. But really we need to move forward in terms of engaging AGYW in research, not in isolation of themselves, but in consideration of the community and environment they live in and the relationships they have that may influence their decision to use or not use HIV prevention products.
Thanks for that, Yvonne. I think in extension of that, another quick thing that we wanted to probably ask was, and this is something that I know, Francis, you mentioned a bit on the segmented work, you know, user segmentation work that you've been doing. Usually we've seen that AGYW and youth in general, the relationship goals override the health goals. Based on your work, maybe if you can share some insights on how can we position messages in a manner that appeals most to this user segment.
Thanks, Devi, Leena. Just before answering that, based on what Yvonne was saying, I think, and in answer to Bernard's question, one group of people that I may not be aware of, but I think is overlooked is men, or men who engage in sex or seek sex under coercion or through transactional sex, if you will. So I know during COVID, there was an upsurge in teenage pregnancies, and it may not be teenage pregnancies in women are caused by teenage men, teenage boys, right? So there's a group there that I think we should look at. In terms of kind of the messaging as well, whenever new products are introduced and we go overdrive on marketing, there will be a temptation of, can I engage in it? What's the, if I may use this term, is it's sexy enough that I can look at it, but the effect, the impact of it is really felt or better understood once they see, this is my peer, they engaged in this. They had a little bit of interaction with a certain product, and this was the result. So I think messaging in that sense, and that's a lot of learning that happens. If you may draw parallels with HIV prevention products for AGYWs, but also say with feminine hygiene products as well, I think there's a lot of parallels that speak to that. And then there's this sense of an identity of, I'm using this product because this is who I am. So I think the messaging and communication needs to take that into account. Thank you.
Thanks so much for that, Francis. And with that, I would probably come to Uttara, who's joined us back. Uttara, in your presentation, you did mention that how, a lot of behavioral interventions focus a lot on knowledge enhancement. However, much is desired, in the space to bridge the gap between intent and action. How can we reimagine youth engagement from that lens?
Thanks for that question, Devi, Leena. I think we do really need to look at the other aspects that surround beyond.
Unfortunately, I think we are losing you.
Because if you think about young people, they're on the steps to behavior change. Some people have the knowledge, also lack certain things like, I've turned off my video just in the hope that the bandwidth will be conserved. Can you hear me? Can you hear me? Okay,
yes,
great.
We can.
Okay, great. Just to very quickly say that I think we do need to consider where young people are by actual behavioral research, understand, is it a knowledge challenge or is it a motivation challenge? Is it a peer approval challenge? Where, we need to design our approaches and our interventions focused on where their barriers are. Not everyone is in the same space in terms of knowledge. I think those assumptions are what we need to challenge when we design programs for young people. We think many programs, we think we know what they need, but really the research is what's going to show us how we can reimagine that. The example that I shared with you from Zambia is just one of many that I'm sure many of my colleagues have great examples as well. We're looking at what exactly is it that young people need to be able to bridge that gap from, where they are to practice, is what we have to examine and see what kind of interventions can fit that more appropriately, whether it's social approval or community support or family support or, peer support. We need to hone in on that based on our research. Thank you.
Thanks for that, Uttara. Anabel, I'm going to come to you quickly, and maybe, if I could understand that there are multiple prevention products that are now being introduced into low and middle income countries. What specific challenges might these countries be facing that behavioral research can help overcome? If you would like to share your insights on that.
Yeah, I think I said earlier, we're at the precipice of a lot of new prevention technologies coming on board, and while we wait for that elusive vaccine, and I think we can learn a lot from family planning in terms of discussion of choice, because the idea is to introduce these products not in a manner that they're competing, but in a manner that we understand that more choice drives more use. If you're thinking you're trying to grow the market for prevention products, you're not trying to drive the market to one product or another. You're just trying to get more people using prevention products. And it doesn't matter which prevention product it is. One day you might want to be using an injectable, the next day you might want to be using PrEP, depending on where you are in your life. And as Uttara was saying, the more prevention products that you have out there, the more likely you are to bridge that gap that Uttara was talking about, that sort of gap for an intention to do something, to actually taking that action. But I think talking about choice, talking about prevention products as a category, not as individual products, and really explaining choice to the women that are out there. And I think it's probably going to take a different way of introducing products rather than individually, but as I said, speaking about them as a category.
Thank you so much, Anabel, for that. I know we are at the hour, but because of the technical glitches, maybe we might overrun by 5 minutes, if that's okay with the panelists. And if all the audiences are fine with it, we would take 5 more minutes. and I'm sure that we won't take too long. Maybe I will have a very quick question for, again, all the panelists as a sum, if you were to summarize your call to action in a line for what we need to do today to make products and design interventions which are centered around AGYW needs, what would that be? Yvonne, maybe we can start with you.
A very simple one for me is, let's not design studies and products in our offices and then go out and carry them out. Let's engage AGYW in the ideation around the studies for HIV prevention products, and also in the design of the actual studies themselves, to really ensure that it's actually AGYW centered. An example is actually even having AGYW on community advisory boards and other, research management processes and bodies. So really just, keeping AGYW at the center of it along the whole way. I do think our sector needs to take some lessons from product marketers, in the food and beverage industry. They're continuously always seeking the consumer's perspective in developing the product and in testing the product, continuously checking whether this is working. So that would be my take from this. Yeah.
Thanks, Yvonne. Maybe I'll pass the ball to Francis. What's your take on that? What would be your call to action?
Yeah, sure. Thank you. One of my favorite behavioral insights model is the BCOM model, which is behavior equals our capabilities, our opportunities, our motivations. A lot of the behavioral research that I've seen is aimed at improving people's knowledge, people's information, but we should also think of the opportunities that are there. Opportunities are there for us to engage way earlier with product developers, as well as better understand the environment in which AGYWs would be operating in. Yeah, thank you.
Thanks for that, Francis. Uttara, over to you.
Thanks, Devi, Leena. I want to just jump off what Francis said about the environment in which young people operate. I think really understanding the social norms, because sometimes to help AGYW, we need to address their parents or gatekeepers or other people who may be creating a challenging environment in which they make their decisions or act. So they're not always the audience, to also consider who some of the other key audiences may be that we need to address.
Thanks for that, Uttara. And over to you, Anabel, quickly.
People do what they get paid to do. So I think from a higher level, we need to incentivize all projects and donors need to incentivize projects to make sure that they do put the user at the center. We all want the user at the center, but the only way to really enshrine that in a program is to make sure that's incentivized in some way in the funding mechanism, and that is recognised and rewarded. So for me, my call to action is make sure that we incentivise good meaningful user inputs across any project and program development.
Thanks for that, Anabel. I think we have some fantastic insights here and actionables here. Before I hand it over to Ashley, I'm going to thank all the panelists here today for sharing your experiences. I think a key takeaway for us is the fact that we've always been talking about, we've been hearing from the communities, from different groups, nothing about us, without us, but there's still a mind shift change that is needed to, and actually very critically, we need to question ourselves that have we done enough to give user the voice they deserve? And with all those actions that were mentioned here, I think there's still a long way to go. An hour is not enough to do justice to this topic, but thank you so much for bringing all those delightful insights on the table. And I'm sure that our audiences really enjoyed the sessions. Over to you, Ashley.
Thanks a lot, Leena. I would also like to thank the attendees for being with us here today. I would like to thank all our panelists and speakers, and I would like to thank you, Leena. I think it was a very rich and fruitful webinar. And before I close this webinar, I would like to ask our attendees to fill in a survey which will pop up after this meeting has been ended, so that we can learn from you what you wish to hear in the future, and where we can improve and how we can bring the message a bit closer to you. And with that, thank you everyone, and have a lovely afternoon and evening.